So dermatology is a largely image-oriented, a visual subject. So most of the questions in INI-CET, especially from the last few years, have been image-oriented. So I want you all to do the same. Just not look at the questions alone, but look at the image also, and try to make a correct answer based on both the image and the question. And we also have to remember that in a multiple choice exam, it is not our target to know the right answer, but to rule out from the four different choices that we are given and to find out what is the most likely answer. And that is what we'll be concentrating on today, how to make a diagnosis from both the images and the cues from the questions, as well as how to rule out different options to finally come to the correct choice. So let us begin. So in the first question, we are discussing the basics of dermatology, that is about the primary and secondary lesions in dermatology. And why are they important? If I want to describe a skin lesion on a patient that I have seen to you, somebody who has not seen it, we need explanation, we need words that are uniform across dermatologists to convey that information so that without seeing, you will understand what I'm talking about. So let us see the first question. So there is a patient who presents with a small raised, so it is an elevated lesion on the forearm that measures about 0.5 centimeter. Which of the following best describes these lesions? So we have options as macule, papule, plaque, and nodule. So let us look at the description of how primary lesions are described in dermatology. So we have few lesions that are like brothers. It basically differentiated depending upon the size of the lesion. So a macule and a patch are basically brothers. So what is common between both? So a macular patch is just a change in color of the skin, but there is no change in texture. That is, if you were to close your eyes and touch on the skin, you will not be able to appreciate if it is a macule or if it is normal skin. But there is a change in color that is well circumscribed. If it is less than 1 centimeter, you would call it a macule. If it is more than 1 centimeter, you would call it a patch. Again, an example for macule would be freckles, most common, and a patch would be vitiligo or melasma. Now let us look at raised, elevated lesions. That is what is given in our question. So in elevated lesions, we have three. One is papule, plaque, and a nodule. So how are these things differentiated? So if you have an elevated lesion that is less than 1 centimeter, that would qualify as a papule. So it would be a papule that you see in acne, a papule that you would see in molluscum contagiosum, which is umbilicated. And now coming to the plaque. So a plaque and a nodule is basically differentiated based on what is the predominant one. Is it the width or is it the depth? If the width is more than the depth, you would qualify it as a plaque. But if it is the depth that is more than the width, that is, it is a deeper lesion, that would qualify as a nodule. And both the plaque and a nodule is more than 1 centimeter. Interestingly, you have to remember that in a plaque, while most common type of plaques are elevated lesions, rarely it can be flat or even slightly depressed. So that, for example, in morphea we call it a plaque, but it is not an elevated lesion, rather it is a flat or slightly atrophied depressed lesion. So why we are calling that also a plaque? So definition of plaque is that not just only a raised lesion, but rather it is the change in texture. That is, if you were to close your eyes and if you were to palpate, you would understand where a plaque is starting and a plaque is ending. That is because there is definite change in texture. So the example of an elevated plaque would be psoriasis, and an example of flat plaque would be morphea. Examples of nodules are again epidermoid cyst and a neurofibroma. Now coming to fluid-filled lesions, we have three lesions. So a vesicle and a bulla are again brothers, differentiated based on what is the size of the lesion. If it is less than 1 centimeter, it is vesicle. If it is more than 1 centimeter, it is a bulla. And what is common between both? That is, it is filled with the fluid. But if it is filled with pus, we would call it again a pustules. And a pustules are usually less than 1 centimeter. Now, examples of a vesicle would be herpes simplex, and a bulla would be pemphigus and pemphigoid group. And a pustule would be again folliculitis, pustular lesions of acne. Now, what is a wheal? So, a wheal is a dermal edema. Because of the edema, because there is a lot of fluid that is in the dermis, the skin becomes elevated. And usually it is transient, lasts less than 24 hours, and the common example is urticaria. Now, these are the primary lesions, and anything that is beyond this would be qualified as a secondary lesion. So, what is a secondary lesion? Secondary lesion is the changes that occur to the over the primary lesions. So, examples include crust, scale, fissure, excoriation, erosions, ulcer, infarct, and atrophy. These terms would be most likely you would understand what are these terms. And lichenification means it is a chronic change where there is increased skin markings, thickening, and hyperpigmentation that is due to repeated rubbing. Now we must remember special primary lesions. These are favorite INI-CET questions, that is burrows and comedones. Where do you see burrows? In scabies. And where do you see comedones? That is in acne. These are not secondary lesions but rather special primary lesions which are diagnostic of these disorders that we have mentioned. So coming to the correct answer, so what is a raised lesion? That would measure more than 0.5 centimeter. That measures 0.5 centimeter. That would be a papule. Now let us go to the second question. So again, let us read the question first. There is a diabetic patient that is coming to the OPD. So in a question, we will have a lot of things that is cues for the answers, and we'll have a lot of distractions. So it is important for us to pick up the cues and discard the distractions that are present. So in this, we are not sure if the diabetes is important or not. Let us see that there is the rest of the question. So there is a lesion in the axilla. So there is a lesion in the axilla that is shown in the picture, and the lesion shows coral pink fluorescence on wood slab. I think we almost have our answer now. Right. So which is the organism that is responsible for the same? So this is erythrasma, and erythrasma would show pink, coral pink fluorescence on wood slab, and it is caused by Corynebacterium minutissimum. So Corynebacterium is again a bacteria, so that is causing erythrasma. And it has a predilection for warmer sites. So it is most commonly present in the flexures, that is axilla, the groin, etc. Now, what are the common DDs of a lesion that is present in the axilla groin like this? So there is a lesion in the axilla growing like this, and we need to know what are the differentials for that. So one of them would be erythrasma, as we had discussed. It is usually brown black in color. Erythrasma means red erythema, but in Indian skin, that is skin of our tone, so we can expect a brown lesion rather than a red lesion. Another disorder that presents in axilla groin is tinea infections. But in a tinea infection, you would expect a erythematous raised border. There is an active raised border in the periphery. And another disorder is candidiasis. And in candidiasis, what you would expect, in addition to erythema and a white coating, would be satellite pustules, which are not present in these. They have not mentioned if the lesions are symptomatic or not, but erythrasma is usually asymptomatic, can be itchy on sweating, etc., but usually asymptomatic, while the other two conditions can be itchy. Now, coming to the wood slab fluorescence, I'm only talking about the very basic stuff that you should be knowing, that without knowing this, you should not go to the exam. So, the wavelength is usually 365. Sorry. So the wavelength, peak wavelength is 365 nm. So it is a blue light. And now coming to the disorders that we can identify on with the help of wood slab, or which aid in the diagnosis, are tinea capitis, in which microsporum species which show as a blue-green fluorescence. Favus, due to Trichophyton cholni, will show as blue-white. And erythrasma, again, as we mentioned, would show coral red. And P. versicolor, caused by Malassezia, will show a faint yellow color. And in porphyria, you can have urine, feces, blister fluid, and teeth, and red and pink. If the teeth is present, it is usually erythropoietic porphyria. Now let us look at the third question. So match the following. So this contains a test of investigations. The dermatology is mostly a visual diagnosis, and we have few investigations, laboratory investigations that help us, that aid us in the diagnosis. So it is easy to learn. There are only very few. So the most important ones are already mentioned in this question. So we have patch test, KOH mount, biopsy, and slit skin smear on one side. Then we have leprosy, lupus vulgaris, contact dermatitis, and tinea corporis on the other side. So let us look at these options. So what is a patch test for? So a patch test basically identifies type 4 hypersensitivity. In a type 4 hypersensitivity, what happens? The patient or the person is already sensitized. It previously has been exposed to the antigen and on a repeat exposure because of the memory T cells. So there is a delayed type 4 hypersensitivity. So the contact dermatitis that patch test detects is an allergic contact dermatitis or type 4 contact dermatitis. And sometimes it is also used in the diagnosis, aid in the diagnosis or identifying the causative drug in delayed type 4 drug hypersensitivity. The examples include AGEP, fixed drop eruptions, and sometimes even in SJSTN. The sensitivity is not 100%. That is, if you have an allergy, it is not always possible to detect it on a patch test. But if it is positive, it can definitely aid in identifying the causative drug or narrow down the possibilities of the causative drug in case multiple drugs are suspected. So the common asked question is again only contact dermatitis, not delayed type 4 hypersensitivity has not been asked so far. Now let us look at what is KOH mount. So KOH is used to identify fungal infections as we already know. So what are the common slides that may come as images in the exam? So let us look at tinea. So tinea presents as a refractile branching hyphae as we can see here. These are the branching hyphae. And this is something we regularly use in our clinic to identify if the patient has tinea, especially in cases we are not very sure. Now let us look at the other slide that usually we use, that is candidiasis. So what does candidiasis show? Candidiasis show these budding yeast cells. So you can see this is a yeast cell which is giving away to a baby yeast. So this is budding yeast cells. Sometimes they can form pseudo hyphae like this. So you will see budding yeast cells as well as a pseudo hyphae. Now let us look at pityriasis versicolor. In this, you see the spaghetti and meatball appearance. The name sometimes confuses because this is not something that we eat in our part of the world. But so what basically it means is that you have meatballs which are round in shape, Then you have fungal elements that are like noodles. So this is spaghetti and meatball appearance. Okay. Now coming to the fourth important one that usually comes for an exam, that is medlar or sclerotic or muriform bodies. These are the different names for the same thing that we are seeing under a microscope, and it is seen in chromoblastomycosis. It is diagnostic. It has been asked previously, and this picture is something you should not forget. Now let us see what a slit skin smear is used for. We already know it. It is for leprosy. And a Zhang smear, it is again one another lab test that we usually do it as a bedside procedure. That helps us in diagnosis of pemphigus group of disorders, which will show an acantholytic cell, and in herpes simplex and herpes zoster virus infections, in which you will see acantholysis with multinucleate giant cells. Now let us go back to the question. So a patch test, as we know, would diagnose or help in the diagnosis of a contact dermatitis. A KOH mount will help in tinea infections. A slit skin smear will help in leprosy. And what is left, a biopsy will help in lupus vulgaris. So what is lupus vulgaris? Lupus vulgaris is a form of cutaneous tuberculosis. And in a cutaneous tuberculosis, it is not, in any form of cutaneous tuberculosis, it is not very easy to isolate the organism from the biopsy. So what aids us in diagnosis is usually a skin biopsy, which will show characteristic features of lupus vulgaris, which is beyond the scope of discussion of this class, right? Now let us look at the fourth question. So we are to match type of scales with their associated conditions. So we have collarette scales, silvery scales, mica-like scales, and briny scales. And on the other side, we have pityriasis versicolor, pityriasis rosea, psoriasis, and pityriasis lichenoides. So let us look at the important types of scales that you should not forget before you go for the exam. One is the collarette of scale. Why it is called as collarette? Because it is like a collar. It is surrounding the lesion like a collar. It is usually, as we can see, if you look closely, it is usually peripherally attached and centrally detached. That is why it is also known as a hanging curtain sign. And characteristically, it is seen in pityriasis rosea. Now let us look at the silvery scales, the well-known scale that almost all of you would know, that is seen in psoriasis. So accentuation of these scales on grating it with a slide is known as grattage test. Now let us look at mica-like scales that is seen in pityriasis lichenoides. So as we can see, these are small lesions which overlying white to gray to brown scales, and these scales can be taken out in toto. That is why it is known as mica-like scales. Now the famous, almost all of you might know, the powdery fine briny scales of pityriasis versicolor. It may not be usually apparent on clinical examination. Sometimes you have to scratch it and that will get accentuated, which is known as Besnier's sign. Now we have yellow and greasy scales of seborrheic dermatitis, very difficult to miss, very classic. Now coming to ichthyotic disorders, we have three named type of scales that you should not forget, and sometimes in exams that can be the cue to the correct answer. Sometimes C in the scale may not help you, or you may be having difficulties, but the words sometimes are given for you to go to the correct answer. If it is fish-like scales, it is ichthyosis vulgaris. If they are mentioning armor-like scale, you see it is like a tight armor that is being kept on the chest. That is known as harlequin ichthyosis. And plate-like scale is seen in lamellar ichthyosis. So the correct answer, the sequence would be collarate of scale is seen in pityriasis rosea. Silvery scales again, our favorite psoriasis, mica-like scales in pityriasis lichenoides, and briny scales in pityriasis versicolor.